I normally don't put myself on the program when I organize a program and contribute to it, but Dr. Jensen insisted that I speak, so I'm here. So I appreciate the opportunity and the honor of your attention.
What is the topic of conditioning?
And it's really an interesting topic. Patients who present with non-restorable teeth, you know, they want something fixed in general. That's what they want. But how do you handle the teeth? And so I'm thinking, okay, I could take them out and put implants in immediately. That sounds like a good idea. Everyone says, oh, I do that all the time. And then, or you could delay the implant placement, which has some advantages. Or you could stage the extractions in the implant. So I said to myself, you ever talk to yourself? I said, self, what's the literature really show on this? And so I went ahead and I did a literature review. And I've just submitted this for publication and it's been accepted. So I looked at PubMed and I looked at 210 articles, and they're systematic reviews, not systemic reviews, systematic reviews. And they're all clinical trials or systematic reviews, so they had data on them. And it's interesting. If you look at the systemic reviews, and again, these are typos. There were 4 of them in particular that were well done. And the relative risk, that RR value of 1.5 to 2.42, indicates that there truly is a relative risk when you put an implant into a fresh extraction site. There is a relative risk, and it's there. When the other thing that's interesting is when you take out a tooth, put an implant in, you know, the extraction site heals. If you remember dental school, you remember how an extraction site heals. There's a lot of remodeling going on and bone formation and movement. And so what happens to the crest? And it may be anatomically specific as well. The anterior maxilla with bundle bone may be different than the posterior mandible, et cetera. So where do you put the implant? Do you put it at the extraction site crest? Do you submerge it a little bit? You know, all these questions from it. And so it's actually interesting that the marginal bone and extraction sites remodeled, and then after it remodeled, it was stable over time. So interesting when you look at that. And this observation was made in full arch cases as well as single sites. So when you look at the literature on extraction sites, you see that there's a relative risk was greater in extraction sites compared to healed sites. So when you put an implant into an extraction site, you realize that there's a relative risk. Then what you do for the patient, you weigh the comorbidities, you look at the site, how bad is it, you know, how is it going to do it, things like that. The other thing is there's an increased bacterial presence in the extraction site. There definitely is, and even if you clean it now, some of these references talked about cleaning the extraction site with all kinds of interesting, you know, things, and it really didn't affect the infection rate afterwards. There's more recession in an extraction site in the anterior maxilla, and that's because of the underlying bone and the remodeling and sometimes thin gingiva, and of course more bone loss in the first year with remodeling. So, you know, what do you do for staging? So if you're going to stage the case, and I want you to start visualizing your own patients, and I'm going to show you a bunch of cases that we've done to show it. You know, you may want to leave a few teeth to hold a fixed provision. Just leave a couple teeth. They're going to be hopeless, but they're not going to be useless. And just make a fixed provisional on them. Just prep them and make a fix. And then take out everything else and do your grafting. Maybe put some implants in selected sites so you can use them later. And then the second surgery you do, which is maybe 4 months later, do what you got to do and place your immediate fix on it or whatever you're doing. So you can stage these. And I'm going to show you examples of when you might consider that as an appropriate treatment. So let's just start some cases. This is a case I did with Dr. Finger and Dr. Schwartz. He's a 70-year-old male. He's got a ablated atrial fib. Now, the cardiologist in New York wanted him to stay on Eliquis forever. The cardiologist in New Orleans said I could take him off. You know, so he lives in New Orleans, so we went that way. He's otherwise healthy. He plays the trumpet. A lot of musicians in New Orleans. So to play the trumpet, you need lower anterior teeth. I don't know if you knew that. To have the bell on, you know, the fix. So to play the trumpet, he needs something fixed. It's interesting. And when you look at his X-rays, you can see that he's got some bone lysis there, some lytic areas. You can see on the 3D. It's pretty easy to see. And now on the left side, he's got that premolar canine, whatever that tooth is, with a little apical lesion there. And you can see on the cross sections, he's got some issues. So this is a case that I'd like to stage, because if I put implants in, And what I do is I plan it. So I plan to put implants in, and I'm going to show you the plan in a second, but basically that canine on the right side that has that lytic area on it, which is, a problem area. That's a tough area to put implants in, right over here. See that, the green there, see right there? So if I'm going to put an implant in there, I'm going to have to shave the whole bone down. And I'm going to tell you right now, I'm against removing bone. I don't like removing bone. You remove it and it's gone. So I like to keep it unless I need it for some reason. So I tend not to remove bone. That's just me. I just don't think it's the right thing to do. So I don't do it. So we're gonna prep them, and I'm not gonna prep them. I don't. But here's the plan. I just put this on the XNAV, and you can see 5 implants in place. But you can see some of the implants are going to be placed in some of those lytic areas, which is not good. Now, when I take the teeth out on this case, this is what I'm looking at. Now, he bled pretty good because he really didn't get off his Eliquis. But look at this defect here. Those are difficult areas to place implants. I think they're hard. Now, you can put them in and you can graft them and you can put membranes on and all that. But to me, that's not an easy place to put. Or I could just take all the bone off, which again, I don't like doing. So I grafted him. I just grafted the site, just like a single, implant site. I convert my full arches into a bunch of single teeth. That's how I look at them. And so if I have a single tooth site, if I'm going to put an implant in that canine site just for the canine, I'm going to graft that site and come back 4 months later and put the implant in. So that's what I do. So I grafted him, and you notice there's 2 prep teeth over here, one here and one over here. And so he had a fixed bridge put on there. So I grafted him, I sewed him up. I use chromic. I sutured him up. I keep it simple, put allograft in the site, put some bioexclude over it or something like that, whatever, the clot or whatever I'm using. And then I wave my hands over it and I sew him up. So I'm done. And then he goes over to Dr. Finger and he puts the fixed bridge in. So he comes back now, and now he's healed. Now everything's healed up, and now we got a site we can do anything we want. So staging this was really key though, because now I've got the environment to have success long-term. And even though he's a little older and he's got atrial fib and all that kind of stuff, it's still not bad. So then we went ahead and did a dual scan on him, and we put the implants in their desired locations. So this is the key. They're placed in their desired locations. So I'm always thinking of the final setup. And I'm thinking, okay, we're going to put these in and we want to put them in the right spot. So no compromise, good bone height, nice long implants. I think I used the 375s by 13s or whatever they are. And here the multi-unit abutments placed on them. I sutured them up, and then I sent them over to Dr. Schwartz and Dr. Finger. And I think they're lined up relatively straight up and down. Not bad for this case. Some of my implants are not perfectly straight up and down, as Dr. Schwartz can tell you. But I mean, most of them are. And he goes over to their office, which is 10 minutes away, and he gets a fixed provisional place. And he's good. You notice that there's room to clean. There's room to clean. Notice that's key. Got to clean. And then he heals up, and then he gets converted to the final. So, and then, that's his routine stuff, and Dr. Finger did the prosthetic. So everybody's happy with this case. The staging is key. The staging, using those 2 teeth for fixed provisionals, made this easy for the patient. He would not do well wearing a denture. He just wouldn't do well. So this was an easy treatment for him. He never had to go with removable. Most of your patients would like that. They would like that idea. So this woman comes in. She's 48 years old. And I know I'm moving quick. Is that okay that I'm moving quick? Because I got some, we're good? If you have a question while I'm talking, raise your hand and we can answer your question quickly. So just so you make sure we get that. So 48-year-old female, nice young lady. She's got a little hypertension. She's pretty healthy. She doesn't smoke, doesn't drink. I said, what can I do for you? She said, I'm ugly. I said, no, you're not ugly. You're beautiful. Your teeth don't do you justice. So that's the term I use. I don't know if you ever use that term, but it's useful. But if you can see on her, she's got, the overbite overjet problem here. The anteriors are very flared and they're out. She's got a little problem with number 8. You can see the gingiva. She's missing her canine. It's actually a case that Dr. Hartman and I published. But you can see the canine is impacted on the upper right side. So what I do on these cases is I don't like stone models and wax ups. I find that they're pain in the neck. So I just put them on the CT planning software that I use and I work it up. And when I work this case up, I'm gonna put implants in angled over here. They're gonna be angled. They're gonna be some over here, some over here, some over there. And so the first thing we're gonna do though, this is a case that I find really difficult to nail. I really find it hard to get it perfect, just everything at one time. I just find it really hard. So what we're going to do, the general dentist on this case prepped the premolars, the premolar teeth. And he prepped them. He took a digital impression on them, sent it to the lab. Mr. Lars Hansen he went ahead and made milled out a provisional. So when I take the teeth out and I do everything else I need to do to stage it, he can then put in this fixed provisional based on a virtual plan that he had already set up. So the virtual plan set up, and so we do that. We put 4 implants in, and we take out some of the teeth, and I put some implants in, and we put this fixed bridge in there right away. And you can see, she's looking much better. She started crying when the bridge went in. She was so happy. And so now I'm not going to talk about the color of the bridge and all that, because I don't do that. I thought it looked okay. And then down the road, what we're going to do to stage this, again, we're navigating all these implants. So I navigated these implants, believe it or not, they were navigated, even though one's out a little bit. But so then what we do after they integrate, I expose them, I put the retentive copings on them, and I put the clip in for the XNav on the implants. So the implants now that we put in are now going to be our stability for the clip, so we can navigate everything. So that's what I do. So now we got the plan. This is the original plan that Lars did in the lab. And so we got the plan, and we put the clip in, and we got the implants in angled, and then we go ahead and put the implants in. So this is the plan. This is our operative plan here, and that's what we did. So, but it was all staged. So she went from the 2 premolar preps on either side with a fixed bridge in there as her transitional appliance, while everything else healed, because we needed some. I had to graft the molar site, things like that, and so we were able to get everything in, and she transitioned just great. And then when I exposed those other implants, I sent her over to the dentist, and the restorative dentist went ahead and took. He put scannable abutments on it and scanned the case. So now we were able to retain the fixed provisional, and he could pick up the other implants, the other 4 implants, very easily. So that's what we did on the case. So here it is. I did the surgery on the second stage with the clip on the anterior implants, put the implants in angled posteriorly, and then another one in the premolar extraction site. And then the fixed bridge that Lars had made for the dentist, it was Dr. Camazzulli. He just put it right in, and it didn't take him, took him about an hour or so to reline it and pick it up. It was pretty easy, and pretty reasonable solution for her. And she's now getting the final bridge made. So we may do a little work up here to line that up, but that's about it. I mean, she's otherwise pretty reasonable. Notice there's no flange on this case. It's all, what do you call it, FP1? I call it crown and bridge, just basically teeth. And so I treat a lot of these full arch cases just like they have single teeth. I'm not big on cutting big flaps, and my patients don't like that. They just don't like having their gums all the way up to their eyeballs. They don't like that. So I find this easy. It's easy for me surgically too. And the patients, they don't break a sweat. So it's pretty simple. So this is a case that I did of Dr. Schwartz and Dr. Finger, and an 80-year-old female referred from another oral surgeon who said, I don't want to deal with this. And she was told by Clear Choice that she needs all her teeth removed. So I look at her, and she's a nice lady. Her daughter's an anesthesiologist. And so, we said, why don't we see what teeth are restorable up there? And so Dr. Schwartz went ahead and took all the upper stuff off. And then he said, there's 4 teeth that are restorable. And the second molar is actually quite useful. So I said, okay, good. So that means on the upper, we're just doing 2 quadrants of implants. You can do those all day long. It's easy to do, little sinus things here and there, and some extraction sites. And on the bottom, though, we're going to have to deal with some of this lytic area here. And also, really, I'm going to show you the problem on this case was right over here in the lower left. So, here she is pre-op, and you can see her lower teeth here. And basically, these are going to be prepped for a fixed bridge. Here's the upper, and you see the partial, and you can see this lateral is going to go, and you can see she's a little bit almost class 2 with her deep bite. So the implant position is going to be a little bit, on the sketchy side. But here's the problem: is that I couldn't put in an implant right there very easy. Even angling it, I didn't have enough bone. So I was worried about doing that. Otherwise, I'd have done everything at one time on the lower. So we staged it. I took out the premolar, and I grafted in the side as well as posteriorly a little bit to give us enough bone later on to put the implant in angled in that area. So that's why we staged it. So Dr. Schwartz prepped the 2 canines and made her a fixed bridge. And so what you see here is the implants are in the upper. That's easy. We did the sinus grafting and things we needed to do. So now we have quadrants of fixed in the front, and then 2 quadrants of fixed in the upper left. So the upper is easy. The upper is pretty simple. And she's transitioned with a fixed bridge, with a provisional bridge. And on the bottom, I got these two implants in. And then as they integrated, we went ahead and put clips here, and then we were able to navigate the implant angled over here, which is what we did. And you can see the clip is placed now, so I can navigate the angle. And I like navigating this because even though I've done a lot of these freehand, I'm still better if I navigate it. So I navigate just about everything. I don't take the chance of not navigating. So if I was doing implants, if you're doing implants and you're not navigating and you're worried about static guides, just go over there and buy that X-Nav and you're done. And the photogrammetry that comes with it is just exquisite. So you're gonna like it. Anyway, so here she is. Now, then we were gonna wait a certain length of time, but her teeth broke. They fractured. So we had to move it up a little bit, but that's okay. We moved it up and we did the surgery and put the implants in, and here she is fixed. So I needed an angled abutment over here on the anterior to get everything lined up. But Dr. Schwartz did all this with a digital plan. I mean, he scanned it, he did digital, and he did it all digital, and it worked out great. And she looks pretty good. So this is a patient that we staged on the lower because I needed to bone graft one particular area to get ideal implant positioning. See, ideal implant positioning is going to give you a long-term successful result. Long-term is good. She's 80, so you're thinking, how long is she going to live? Well, my mother-in-law is 101. And so I'm thinking, all right, maybe she's going to live as long as my mother-in-law. I hope she doesn't, but you never know. I mean, 101 is pretty old. Anyway, I love my mother-in-law. I'll just leave it like that. All right. So you can see she's fixed. She got the fixed upper. Everything's in place. Beautiful aesthetics here. The lower's done. You see that one implant's a little bit lingual, but she's got space to clean and she's doing well. And they have a good hygiene schedule for her. So, but you see the staging on this case is key. That's the key, was the staging to allow the bone graft to heal. So, sometimes when you want to put ideal implants in, you can. You just have to adjust the patient to be able to do that. But every time I've tried to take a shortcut on that, I wished I had, every single time. So I tend to be pretty definitive. I tell the patient, it's going to take a couple surgeries. We're going to get you done, but in the long term, it's better to do it this way. Well, I want it right away. I said, no, it's not going to happen. I just tell them it's not going to happen. I don't give them the option. I don't let them decide for me. I give them the professional option of what to do. Maybe I'm a little hardcore, but that's okay. So this woman comes in, and I'm doing pretty good with timing. Actually, I'm doing better than I thought, so it's even better. So I'm going to take a little more time on this case. This woman comes in to see me in 2015. She's 63 years old, married to a very famous actor, and so she's flying all over the world with this guy. I mean, they're filming all over the place, and I think she's in France right now. But anyway. So she comes in and she's referred to me by a local dentist for this upper right quadrant here, 2 and 4, and so I'm thinking, all right, good. And I take the x-rays, and sure enough, those teeth are not restorable and they need to come out. And when I look at the scan, I like to look at a lateral view of this to make sure that her mandibular plane angle is right. She's not overclosed. It gives me a quick look at the vertical dimension. So I think she's doing pretty good there. I mean, her mandibular plane angle is about right. And so vertically, I think we're okay on that. Now, so we look at her, and if you look at her carefully, you'll see she's got this fixed bridge from canine to canine, canine to canine. And I'm looking at him going like, okay, and she's got that little depression above it. I see these all the time. I see this, a lot of dentistry has been done in the past, great dentistry, canine to canine bridge, nothing anteriorly. I see that all the time. And there's nothing wrong with it. It's good treatment. It's just sometimes things go bad with it. Now, what happened in this woman is if you look at those two canines right here, those two cross sections, there's not a whole lot of bone holding those teeth in, is there? Is there a lot of bone? No. So I want you to think about this. So, and then if you look at these pictures here, you can see how narrow the ridge is anteriorly. I'm not sure what that is, but just to let you know, it's an old thing that she had done a long time ago. But look how thin the ridges are. And when you look at that, you go, okay, when she loses those teeth, because she's healthy. When she loses those teeth, what are you going to do for her? What are you going to do? So I looked at her. I said, well, we got to figure out a plan. So I told her the prognosis of the anterior bridge is poor. It's going to break. She said, when? I said, sometime between now and then. And she looked at me. She went, what's that mean? I said, now and then. It may be now, and it may be 10 years from now, and maybe 20 years, and maybe tomorrow. I don't know. But it's going to break. And she went, okay, what do I do when it breaks? I said, well, right now, you're going to have a bone graft done, and you're going to have this done and that done, and it's going to be a mess. You have to wear a denture. So I don't want to do that. I said, I know you don't. So let me just show you another case, just to show you if you don't get proactive on this. This is a woman that comes in to see me, a different patient. Canine to canine again. See, we see this, and she broke that. And you can see most of these cases are narrow in the anterior maxilla. So that's okay. So on this case, what I did was I made an incision, reflected it, did a bone graft on her. I did a particulate graft with xenograft and membrane and all that kind of stuff. Sewed her up, waited 9 months, did guided surgery, and she has fixed in the front. And basically, two canines and two centrals are what we use on those anterior 6. And she's a little bimax protrusive. It's an ethnic thing on her. But that's good. I mean, that's 12 years, by the way, on the bottom. 12 years. So good longevity on this. And notice it's really well done as far as the prosthetics. You can see where the implants are emerging. You can clean it. It's just, there's no flange. It's just basic stuff. So that works well. So now let's go back to this lady. What am I going to do in this lady? So I'm looking at, this is the woman that I just showed you. You can see it 2011, 1023. You can see the bone graft that I'm using, which is a high temperature xenograft. The high temperature treated xenografts mean that it's almost like a synthetic hydroxylapatite. It doesn't resorb. It doesn't go away. It's from the femoral head of the cow. So it's macroporous, so you're going to get bony in channels. I mean, it's got 50 to 100 micron pores in there. So you can get bone in there. That's basic bone healing physiology. So that material works well. It's good. And so going back to this woman, what am I going to do? So I said to her, I think you need to have an augmentation done sooner than later. Why? I said, because there's no reason that we can't augment you now. And then when it breaks, we're ready to go. And she went, that sounds good. I said, okay. So she said, do I have to lose my teeth? I said, no, you keep your teeth. So we're keeping her teeth. So in this case, we're staging it only because we're keeping the bridge in. And I've got other patients that we do this too. They come in with a bridge that's failing, teeth are failing, but they got the concavity and the loss of teeth. I'll augment them with the bridge intact and then eventually take it out and put the implants in. So I find that to be an easy way of treating them. And they're comfortable. So what we're going to do in this case is we're going to augment the anterior maxilla on that. And we're going to do it with the teeth intact. And I told her, I said, I don't know when they're going to break. And she said, I know, between now and then. I said, that's right. So this is what we did on her. And I have the dates on it so you can see the dates. So we took out the 2 teeth that were bad, the 2 and 4 teeth, and grafted the sockets. Then I came back and I did the anterior ridge augmentation from a tunnel. I'll show you that in a minute. And I did that in July of 15. And then I did sinus grafts on the right side because we needed more bone. Did that, and then we put the implants in June of 16. So she would fly in, I'd do the surgery, fly out. She'd come in and fly out. So I don't know, she liked me, so we did that. And her husband, who was, again, this actor, so one time he was in my waiting room, and he was reading a script, and he made some notes on it, and he said, I don't like this, and he tore it out, and he threw it in the garbage can. Well, my wife went, so she was in my office, she went into the garbage can and took it. So it's a souvenir of this guy. Anyway, long story. Anyway, so how am I going to do this? So I'm going to make an incision up there, and I'm going to do this with a tunnel. I'm going to do it closed. I don't like making incisions on the crest and sewing it up because I find that they dehiss a lot. So I tend to be conservative on my incisions. So I do a tunnel. We've been tunneling for augmentations for a long time. Corey does it. He does vertical incisions. Zada does. I mean, this is not a new thing. So we tunnel, and then I'm going to augment the ridge that you see across the arch and also posteriorly. I'm going to go a little posterior. So from that one incision, I can go across. If I need to make another incision, I can, on the other side. But, you could basically do it. The instrumentation for this, I use a number 7 periosteal elevator. You go to H&H, you can get the Zada set from him, which has little curves on it, so you can get up and over some of the irregularities. It's a really nice set. And if you go over there, tell Lincoln you want the mic block discount. That's the key. So now here's my incision. As you can see here, up there, my light's going out. So you can see the incision. I made the subperiosteal tunnel. I put the material in, and I sew her up. That's about what I did. And it doesn't take long to do. It's a simple surgery. You got to be on bone. You put the graft in there. Yeah, I put a lot of graft in there. I mean, I grafted it pretty good. But then again, I don't want to have to come back and do it again. So that's in 2015. And you can see now, this is now 17, we've done the sinus graft, put the implants in, I'm testing the implants. So now you can see the graft is still in place, but now you can see it's sort of coalescing. You can see the bone to that is pretty good. So we're in pretty good shape with the bone and the graft. And she goes, bye-bye. And so she disappears. She gets her crowns on the upper right and she goes away. So and then she calls me, said, I broke the bridge. I said, okay, good. So she comes in, and this is November 23. So this is relatively recently. She comes in and I said, well, she says, well, you told me that you could take the teeth out and put implants right in. I get a fixed set of teeth. I said, that's right. She said, can you still do that? I said, well, let me take an x-ray. So that little gap that she has in here, she doesn't mind. She doesn't mind that gap. She likes that gap. Johnny doesn't like that gap, but she likes the gap. I mean, so we're going to end up somewhere in between, I think. So when I look at her now, this is a November 23, you can see that the implants in site 3 and 4, which are on your left, look okay. The grafts from all the way across the arch look good. I mean, they're still there. That's the reason I use that high temperature xenograft. It stays in place for a long time. Well, I have 30, 40 years on this stuff. So it goes a long time. And we've published it. So now I'm going to describe the sequences to the patient. I said, okay, this is what we're going to do. So I'm going to get an intraoral scan on you. So I take my intraoral scanner, I scan the maxilla. Why? Because that's my plan for surgery. Her teeth look great. So I'm going to use the same tooth. And I say, Johnny said, okay, yeah, fine. So I scan her. Now I got my plan. I'm all set. I haven't taken the teeth out yet. So I've got my intraoral scan on her. I just do that right away. It takes me, 7 minutes, 10 minutes, doesn't take long. And then I take that plan and I put it on her. I take the clip for the XNAV and I put it on the right side where those implants were. So the clip is on the right side. I got the plan in place and then I could plan the implants. And I plan them so Johnny can do the prosthetics. And I said, you like that? I sent him a JPEG of it or something. He said, yeah, it looks good. I said, all right, he's pretty easy to work with. So it's pretty simple. So far, so now how are we going to sequence this? So I see the patient on day 1. So she comes to see me and I see her and I said, okay, you have available bone. And I got a plan. So then I send it over to Johnny. He says, yeah, send her over. So he sees her and he takes an intraoral scan, takes some pictures, and he develops a plan. He develops his final prosthetic plan virtually, which is, easy. I mean, pop, done. I just said that. He's probably smiling, going like, it's a little more involved than that. But I mean, how hard is it? You put virtual teeth in, they line up, and they're about done. That's a surgeon looking at it. I'm just going to tell you that. All right. So it may be different. And then he said, okay, I'm ready. So she comes to see me, which is day 3, which is actually on Monday because we're not going to do it on the weekend. And I put the implants in the morning, early in the morning. It doesn't take me long, take out the teeth, put the implants in, they're guided, I'll show them to you. And then she goes over to see Johnny and he puts the tie bases in, scans her. Then he incorporates the plan that he's already got onto the scan, and then he puts the bill provisional in later that day. It is that easy. So your recipe for success on this is boom, 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 done. So this is the tie base, which is what he likes to use. And this is one of the ones that we used on this patient were non-engaging rather than the hex. But it's a scannable thing. You can see them. I mean, Ditron have them. It's a Ditron part, and it works great. The interfaces are good, and he uses that. And then this is the surgery that we're doing on her. I think surgery. Yeah, there it's running. This is show you a little surgery, and then I'll stop. I got a minute and 19 seconds. So I'm going to make the incisions, and I'm going to reflect the tissue. Well, when I take out the canine teeth, I like to preserve all the bones. So I'm going to use the piezo to go and take the teeth out, so preserving that labial bone. I don't know how many of you take out canine teeth in the maxilla, but you can lose the labial plate pretty easy. So I tend to keep it. And then I reflect the tissue. There's the clip in place. She just wanted local. She didn't want to be sedated. I said, that's fine. I numbed her up so she wasn't hurting. And then I'm putting the implants in. I'm looking at the screen when I'm doing this. So I'm looking at the screen and I'm drilling a hole. And it's pretty simple. It's not a complex thing to do. And then you go through the series of drills for the system. It's pretty basic, you size it up, but because it's a straight drill and a tapered implant, you got to stage it a little bit, sequence it, but that's easy to do. And then you screw the suckers in. And I set my drill at 50 Newton centimeters. So normally it torques out, and then I go ahead and torque it. And I always like the internal flat in the implant to be to the labial. I try to make that routine because most of your angled abutments come off of that flat. And I think you notice that, if I'm going to angle them on purpose, I make sure the flat is angled so that the angle correction goes the right way. But you see that's the premolar site that you didn't have a tooth in place. So I'm putting the implants in, and you notice I won't drill really fast. Sometimes I take my foot off the accelerator there and not drill full speed. So I'm just trying to think about the bone and I'm trying to think of how I could not screw this up. So I like to be real gentle on the bone. I find if you're gentle on the tissue, gentle on the bone, it works better. So you hear the thing, it torqued out at 50, and then I just crank it down. It's an alloy, so you can crank this thing down all day long. versus a commercially pure titanium implant, which you may deform. So now I put the 5 millimeter tall healing abutments on it, and then we send her over to Dr. You can see the implants the teeth that came out in the bridge. I sent the bridge over to him. I don't know why, but I did. I thought maybe it'd be useful. It wasn't, but it's okay. The thought was there. So I put these healing abutments on there, 5 millimeters tall. I sew her up. I put a little grafting around certain areas, but it's very, very loose, very, very loose. So he can very easily unscrew them, puts the tie bases on. And then, so this is my immediate post-op. And you see, I'm in the grafts, so everything looks pretty good. And here she is, she's 1 week now. I mean, you can see, his work is pretty damn good. And you can see the implants, coming out. So she's doing well. She's now about 8 weeks post-op and doing super. So, I just saw her and on her way to France, and then she was going from France somewhere else, and she moves along. So that's pretty much what I wanted to talk to you about. I want to thank you for your attention.